good afternoon, everyone, and a warm welcome. Our next presentation is Dr. Christopher Gottschalk, and he is currently Director of the Yale Headache and Facial Pain Programme and Chief of the Section of General Neurology. This programme provides training to medical students, residents in neurology, as well as primary care and fellows in headache, as well as pain medicine. Dr. Gottschalk's primary research interest is in education from neurology trainees and primary care physicians to the general public regarding the facts of headache disorders and the fictions that interfere with their recognition and treatment. He's active in curriculum development at the American Headache Society, the AHS, working to establish milestones for headache medicine knowledge and practice over the full range of medical education programs. He was UCNS board certified in headache medicine in 2012. Dr. Gottschalk was fortunate to have worked briefly with the late Andrew Sewell in his tenure at Yale, and proud that we have carried on his project to study the use of psilocybin in primary headache disorders. And his presentation today, entitled Ponderings and Pediatrics, is about to start now, and I'll hand over to Chris. Thank you, Chris.
Thank you, Ainsley, and thank you for a very kind introduction. It's always a pleasure to be here.
Thank you.
Can you all see my my slide presentation there?
Yes, we can.
All right, great. So my hope today was just to review a few points of information gathered from several different studies, mostly surveys, over the last couple of years that I think highlight some important points about all the things that we continue to not to know well enough about cluster headache in terms of what's really out there, and a few interesting points about what we have learned or do know. So what can we say about what's new in cluster headache research? It is still true, thanks primarily to the work, the ongoing work of Drs. Shore and Burish in the cluster headache questionnaire, that this remains the most painful condition known. It is an important point, which I will emphasize today, that childhood onset of cluster headache is more common than most doctors realize. And as I've been looking into this data, I'm a little disappointed to find out that even among headache doctors, this is not a well-recognized concept. So that's clearly something that needs to be addressed. I'm happy to say that diagnostic delay from the time of onset to cluster headache seems to be improving, at least in some countries, although it's apparently not true for everyone, and we'll talk about why that might be. An important point of looking at today's data is that surveys, at least surveys in a given country, or surveys that try to capture the entire population of cluster headache patients, often capture primarily episodic cluster headache, which I think says a lot about the way that that can affect the kinds of results that you get or the picture that people have of cluster. And then we'll talk quickly about a physiological study from a couple of years ago, which makes a really important point about how CGRP works, or really when CGRP works in cluster headache periods. So here's just a quick summary of information from the cluster headache questionnaire, which you heard about before and you will hear about more later today. But just to make that point, that in this questionnaire, when people are asked to rate the severity of pain on a scale of 0 to 10, and comparing what they would rate cluster headache to other disorders, that those numbers are quite shocking, I think. So cluster headache is consistently rated as the most severe pain people know of or can imagine, even compared with labor pain, pancreatitis, and kidney stones. I can tell you that in medical folklore, it is always true that we are taught that those other three conditions, labor, pancreatitis, and kidney stones, are the most painful thing that people can experience. So again, the way that physicians are educated and the memes that exist about what pain is and how bad it is are clearly skewed in relation to what people with cluster headache can tell you. and then a whole range of other things. I am always fascinated and saddened to see, for example, that people consistently rate gunshot wounds as consistently less painful than cluster headache. One interpretation of which, of course, is that many of you would say you'd rather be shot than have another cluster headache attack. I don't think that most physicians or most people in the general population who don't know about cluster would ever imagine that that's true. And I think it's a really important point to make. So here's an updated slide from that same Cluster International online cluster headache questionnaire, which asked people about the age of onset of their own cluster headaches, and clearly shows that there are many of you who report that your first attacks occurred well before the age of 20. In this case, it's about a quarter, so 341 patients as opposed to 1,240 patients with adult onset. And take a look at the fact that there's a meaningful number of people who report attacks at the age of 10 or 5, which is absolutely out of the view of what most headache specialists are taught. And certainly not what is typically reported in surveys of cluster headache or chapters about cluster headache in medical textbooks. Another interesting point from a recent sub-analysis of this same data is that cluster headache patients with young onset more often report migraine-like symptoms, so sensitivity to light or noise or nausea or something like that, as opposed to those whose onset was at the age of 20 or older. So noticing that that has also been reported in other studies, that migraine symptoms are higher in younger patients, this immediately sets up the possibility that part of the problem is not only that physicians don't expect to see cluster headache in younger patients, but the fact that they endorse symptoms we typically attribute to migraine means that kids with cluster are more likely to be diagnosed with migraine, and so that will lead to some delay. So on that note, I have a quick poll, if we can pop that in, about the age of onset of your cluster headache.
Dr. Gottschalk, can you see the results of the poll coming in?
I can't, I only see the question itself so far.
So we've got about 50% of attendees have responded so far.
Great. I'm in no rush.
For our attendees, I'd just like to mention that Chris is very happy to take questions throughout his presentation and at the end if we have time. So we can interrupt him with questions if you have any. And we have some supporters here with us as well. We have Christy Lancaster, and we love our supporters. Our supporters are our backbone. It's very difficult to live with cluster headache at the best of times, but with help from our supporters and caregivers, it makes it so much easier. So Christy, I know that you can't vote, and our other caregivers, supporters who are here can't vote. As a panelist, I also can't vote, but just for a matter of interest, I was 19 when I had my first cluster headache.
Andrew, I'm happy to close the poll whenever you think it makes sense.
Yeah, that's fine. We can go ahead and get it closed up. I haven't seen anybody else add on there, so we'll wrap
Great.
that.
Okay.
So Chris, we do have a question. May I pose a question to you now from one of our attendees, please?
Please do.
Thank you. So Kathy asks, in your opinion, are these headaches, cluster headaches, inherited? Are they genetic in any way, shape, or form?
It's a great question, which is actually the subject of one of the studies that I'll report later today. So in surveys, yes, there are some people who report onset of cluster, or other members of their family affected. And actually another paper that was just published by Dr. Burish and colleagues looks more specifically at the evidence that we have about that. So it does exist, and there are some interesting points to make about how a family history of cluster headache may be different, or people with a family history of cluster headache may be a little different from people without that. It's a great question.
Thank you.
So looking at these poll results, like, what it shows is, on the one hand, the most common response here is what most of us expect. And that is an important point to make always about statistics and medical education and what you might want to call memes or biases or heuristics, which is, okay, it's fine to say most people have an onset of cluster headache from 20 to 40, something like that. Great. But that does not mean that if they are younger or older than that, that they can't have cluster. And this is always the problem. If you start out with the expectation that a 15-year-old reporting unilateral headaches can't have cluster because that doesn't exist, then you won't make that diagnosis because you have a biased view of that story. And here again, we see that the answers from this group of people confirms that general impression. So here's another set of data that looked at that same question. This is from the Danish cluster headache survey. Keep in mind that in countries in places like Scandinavia, the good news is that because they have a nationalized healthcare system, they're actually able to survey the entire country and look at all diagnoses of a given type, at least for the ones that were given the diagnoses of interest, and then look at something about those patients. So in this case, patients were sent a survey if they'd ever had a cluster headache diagnosis. The majority of them answered and said something, for example, about the onset of their headache. So in the top there, you see age of onset of episodic cluster, noting, for example, that there's a higher rate in men than women, which is typical of most of the information that we have. But again, that there were significant numbers of these people who reported onset at the age of 6 to 10 or 11 to 15 or 16 to 20. So not at all a peak. And in fact, the peak of the age of onset here is under the age of 20, which is again different from what most physicians expect. So this kind of information needs to be presented consistently to headache docs and other doctors, pediatricians, for example, because if they don't expect to see it, they won't see it. And then again, age of onset of chronic cluster headache. So when did you either chronify or present with new onset chronic cluster headache? A little older, but not nearly as much of a sex difference comparing men to women than what we see in episodic cluster headache. Similarly, an older report by a few years from an Italian group, so different country, different cohort, very similar results, overall showing again the differences more striking in episodic cluster between the sexes than chronic. Here, a slightly older skew of the data, but notice that these epochs or groupings 0 to 9, 10 to 19 are larger than the groupings here, which are more like 5 years. So it's a little harder to compare them, but again shows a relatively young onset. Presumably, if this had been broken down, the 20 to 29 group, you'd see more of this group in 20 to 25 than 25 to 30 based on what we see here, something like that. But comparable data, again, showing important numbers of patients who report onset well before the age of 20, and that there's less of a difference in terms of chronic cluster onset in men and women than there is in episodic. So, other interesting information having to do with both typical features of cluster, but also thinking about what physicians expect to hear. Here is a breakdown of many of the typical autonomic symptoms and some other features of patients who were in this Danish cohort, noting, for example, that meiosis, which means a small pupil on the side of the attack, is a relatively uncommon or rare symptom, even though it is presented as this in the typical list of symptoms, you might have lacrimation, conjunctival ejection, rhinorrhea, meiosis, etc., as if those were all roughly equal. Whereas these data say very clearly that tearing on the side of your attack is very common. So is redness, maybe nasal congestion, about half the time, or a runny nose, but actually having a smaller pupil. Now, is that because it happens less often? Is that because people don't look or don't know to look? I will never forget speaking to a cluster headache patient a few years ago, and when I asked this question, he said, not only that, but I can actually see my pupil pulsing with every throb of pain. And I asked him to videotape that, which I have not seen yet, but I imagine that if more of you looked carefully, you would find this feature more often. So again, not hearing about a small pupil does not make it less likely that somebody has cluster headache. Hearing about it is certainly helpful, but not a requirement. And I think in many neurologists' eyes, this would be considered equally important compared to some of the other symptoms. Also note that a surprisingly high percentage of patients reported that at some point their attacks were on the other side. So in general, cluster headache is described as a side-locked headache, a problem that only occurs on one side of the head. And if physician hears that the attacks can happen on the other side or shift to the other side, would almost certainly be put into the probably migraine bin as opposed to probably cluster. So data like this says, don't automatically assume that alternating sides means that this is not cluster, a very important point. And then, not surprisingly, as is true in many, many of these studies, having attacks that begin at night or overnight is an extremely common feature, which again, I think is not commonly presented to neurologists, general neurologists, maybe more often to headache specialists, certainly the people that we train. So all of those are points that are important in terms of not just what do people with cluster tell us, but I think more importantly saying, what do physicians who see you expect to hear or make of some of the things they hear? And that is, I think, a more important point about how to use this kind of information. Another quick point on this slide, which we'll touch on later, is that 7%, 8% of people in this survey said that their attacks lasted more than 3 hours. So you probably all know that the International Classification of Headache Disorders tells us that cluster headache attacks are allowed to last from 15 to 180 minutes. Now, for some physicians, hearing that an attack lasts more than 3 hours, so that means 4 hours, would again make them say, oh, well, then this can't be cluster, it must be migraine. So knowing that these variations exist, like any other disorder, most things are this way, but there are some with other features or who have variations on those features, is not really surprising, but unfortunately not well recognized when it comes to making this diagnosis. And then just a quick point here again about nocturnal onset of attacks in this same group, saying that a large percentage of patients, both episodic and chronic, but more so with chronic, said that their typical time of onset was between 2 and 4 in the morning. It's an interesting feature of cluster that this is the same time point that is, or same time window that is reported in many different countries, many different time zones. So no matter where you are, 2 to 4 a.m. in your time zone is a very common time of onset. The other one is a surprising number to me of patients who were in this study, so 30 to 40% of all the groups, said that there was no particular rhythm. There was no particular predictable timing of attacks, which again, I think for many physicians would immediately mean, or at least for many headache physicians, would immediately mean probably not cluster because it's supposed to have a predictable chronology. Another point to make, similar to what we made earlier, and we'll make again, is this idea that there are commonly migraine type features in cluster, or some. In this study from over 10 years ago, an early observation of a very important clinical teaching point, which is that in episodic cluster headache and in chronic cluster headache, 50 to 80% of patients say that they have sensitivity to light on the side of their pain. Again, in general, physicians would ask a question like, are you sensitive to light during your attacks? And if they hear yes, that would skew their thinking in the direction of migraine. Most physicians, even neurologists, even some headache specialists, I would guess, don't know to then ask, wait a minute, are you saying only on the side of your pain or both eyes? And would also immediately assume that sensitivity to light in the context of a headache attack means this is much more likely to be migraine. This evidence and other evidence like it says not the case. So taking a step back, understanding what the profiles, the range of profiles of cluster headache can look like is very important in terms of getting more people to the right diagnosis sooner. Speaking of which, here's a slide from this relatively recent study in a Danish cohort looking at, among other things, the age of onset again and the diagnostic delay. So this important initial analysis they did said, what do we know about the prior evidence about how long it takes patients to get diagnosed? So when you look back in the 50s and 60s, which is at the very beginning of when cluster headache was really recognized as a disorder, the typical average diagnostic delay in some patients was 25 to 40 years. So this was relatively small numbers of patients. In the 70s and 80s, you're talking more like 10 to 20 years and a higher percent. And then in the 90s and 2000s, still numbers in the 4 to 6% range, but a much higher percentage of people saying it took years to get to the right diagnosis. And then in the 2010s, a more recent study saying as much as 20% said it took about a year. So overall, the trend in diagnostic delay over the entire group of cluster headache patients seems to be getting better. That's encouraging. However, this is, I think, the key point of that study, which is that it was especially true that you had a short diagnostic delay if you were an older person. So somebody in his 40s who says, I get unilateral attacks, blah, 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 fine. Somebody who's 20 or so, much more likely to have a delay in the range of 5 years. And for people whose onset was under 20, forget it. It's as bad as it ever was, even in the 50s when most physicians had never heard of cluster headache or didn't know such a thing existed. So this is, again, evidence that the idea that cluster exists in adolescents or children is not recognized and is a major problem in terms of education that we need to sort out.
Chris, could I ask you we have some questions. Would you mind answering questions before we move on?
Oh, no, please.
So, thank you. One of the questions was from Dr. Larry Shore when we were talking a few slides ago about the statistics of that you collected about attacks flipping sides. He just wants to clarify that you didn't mean, those statistics didn't mean bilateral, both sides during the same attack. That's
correct. Correct. This is between attacks, and I have to say I think I remember from this study, but certainly from other studies, that also typically does not mean switching sides within a given cluster period, but rather that I've had a period on one side, I've had a period on the other. There may be some variations there, but absolutely, we're not talking about during a single attack, but I think just the general recognition that there can be switching at all is something that physicians need to know about.
Great. And we also have a question from Roger, who presented for us just a little while ago. Do you think patient diaries could give a more detailed insight in the patient than a questionnaire?
Absolutely. It is always true that when you subject patients to questionnaires, you introduce all sorts of bias. So you have recall bias, meaning, do I think this ever happened? Sure. They forget about things that were different from the average that they've had, human nature. It's also true that by asking a questionnaire, you are forcing people into a certain number of answers or types of answers that you expect to get, and will miss, by definition, things that you aren't looking for unless you give people the opportunity to give different answers. So the beauty of a prospective diary is absolutely that you get the full range of experiences and not subject to memory loss or recall bias. It's a great point.
Right, thank you. I'll pose one more question to you and let you move on. Ashley has asked, will attendees be able to have access to the slides that you're showing us today?
Absolutely.
Are you able to share those? That's great. Thank you. And we'll go back and take some more questions a little later.
Okay. So moving on to now a study from a Korean cohort, which took a particular approach, which was to look at the value and the information gained from using the headache impact test, the HIT-6, a validated survey, at least in the migraine population, which has at times also been applied to other headache types. So as opposed to, as some of you may know, a scale called the MIDAS, or Migraine Disability Assessment Scale, the HIT-6 is not specifically skewed or aimed at migraine attacks, but simply asks about problems and functioning related to headaches and can be used in others. So they looked at a relatively large cohort. Again, they have access in Korea to an entire national database. In this case, they've developed an online or a prospective registry and surveyed over 200, they got 225 respondents who were talking about who then gave these responses about headache attack related disability in the context of cluster headache. Now, notice here, please, that of those 225 patients that responded, only 5% were people that identified themselves as having chronic cluster, and that the average age of the respondents was 38, as low as 26 or something like that, and as high as 50. But the vast majority of these are men. So immediately there, I think you can ask some questions like, if 84% of Korean respondents or Korean registry members were men, does that mean, for perhaps, that in Korea, women are less likely to get diagnosed with cluster headache? I would guess so. And why is the relative percent of chronic cluster so low? Does that say something about progression of chronic cluster in Korea, perhaps? Or again, is there something there about being given a different diagnosis based on physicians' expectations in that country? Don't know. But in this particular presentation of the data, just looking at how the breakdown of these standard 6 questions in this survey look, you see that about 90% of patients say that they always or frequently had severe pain, and similarly about impairment of social function or role function, meaning in work or family function, and about 60% reported significant cognitive impairment, and about 70% reported, so more than 2/3 reported significant psychological distress associated with their attacks, which I would guess also means with the anticipation or expectation of future attacks. So all of these are very high numbers compared to what you would typically see, for example, in a migraine cohort. What they then did was to break down their group into cluster headache that was very severe, meaning HIT-6 scores that are over 60, which is the usual cutoff for severe, as opposed to those who were not. So in their group, even though the vast majority were episodic patients, the great majority of their respondents met this criterion for having very severe attacks consistently. And it's interesting to note here that the more severe group was younger on average than the less severe group, and that their onset was younger than the more severe than the less severe group. So there again, differences in the breakdown of reported age of onset, of how patients describe the severity of their attacks depending on their age. It is also important to note that in the more severe group were essentially all of the chronic patients. Not surprising to any of you, and certainly not to me, but there was no one in the less severe group who reported having chronic cluster headache. Also, not really surprising, but if you were somebody who reported more severe impairment of various types, you were much more likely to be someone that had longer attacks, 1 to 2 hours, as opposed to shorter attacks in the less severe group. And interestingly, going back to that other survey that looked at some of the profiles of different autonomic symptoms, red eye, tearing, stuffy nose, etc., that there were a higher number of those those features in the more severely affected group. And then down at the bottom of this scale, of this table, is what the authors of this paper considered the main point of their study, which was to look at predictors of severity on the basis of either depression or anxiety scores and their relationship to stress. So here, not surprisingly again, in the group with higher severity, you have a much higher percentage that endorse a significant amount of depression symptoms or anxiety symptoms. Unfortunately, this report, like so many that I see in the context of other headache disorders, immediately says that this means having anxiety predicts more disability. I'm sorry, but that's not what those data mean, at least not to me. It means that they are correlated, that if you have high severity, you are more likely to report depression symptoms of anxiety, fine. But that is not a causal, that information from a study like this cannot tell you anything about the direction of that relationship. So I think it is certainly as likely that people who have long-standing, long-duration, very severe disabling attacks are far more likely to have anxiety about their ability to function in society, about the onset of their next attack, about how much time they're going to lose, about what they're going to do with it, you name it. But the fact that these go together should not automatically be assumed to be a result of anxiety or depression. And this is what I see every single day in practice about the way that patients with headache disorders are seen out there in the world. Also not surprising that the people with the more severe scales or symptom reports endorse more stress related to the severity of the condition. Okay.
Let's take some questions. We have quite a few questions. Would you be okay to take a few questions? So we have a question which asks, do you believe that current intake protocol and first-line treatments for cluster headaches need a change? And if so, what would your ideal look like?
Oh boy, that's a great question and a big one. Well, I mean, current intake protocol, I think for me that means yes, if I interpret that correctly, yes, I think it would really help to provide clinicians with a simple, standardized questionnaire, not simply diagnostic criteria, but how to ask the right questions about cluster headache or about headaches that would include questions that would be able to identify cluster headache in a way that would make it much easier to recognize when somebody doesn't have migraine, when somebody might have cluster, and to gather more consistently information about things like when it started, rather than having biased assumptions about when cluster should or shouldn't start, for example. So yes, I think that's a really important point, and would be presumably a larger, longer set of questions for, say, a headache physician than for a primary care physician or neurologist. But there should be a way to provide a relatively simple set of questions that could help us get to these diagnoses faster. I think that's a great point.
Well,
First,
yeah, it leads on to the next question and a few comments, which asks, how do you and other researchers in this rare condition get this data to neurologists? Seems pretty cut and dry, but the symptoms are not all cut and dried, and that everyone shouldn't be shoved into migraine as a default. Can we patients help the effort to educate? And if so, how? And we've also had some comments saying that, you know, as a patient, very surprised that such a misunderstood disease, that doctors can be very narrow-minded sometimes in diagnosing, as we've just been talking about. Many of us in the older crowd, myself included, actually had to self-diagnose and educate not only ourselves, but our doctors, you know, being dismissed constantly. Typically, you know, you can't possibly have cluster headaches. You have blue eyes and you're a female. So, you know, this is the kind of things that as a community, I'm sure you're aware that we're getting on a regular basis. Maybe not so much now as in the past. Again, someone said that they're surprised that a pharmaceutical company hasn't developed a simple questionnaire for primary care practitioners. So just filling you in on those questions and those comments, it seems to be a really popular topic to discuss, the misdiagnosis and the firm being told by your physician, no, you know, you don't meet the criteria. And how can we move forward to ensure that neurologists are aware? I know I've seen neurologists in the past, many of them, who had never ever treated a cluster patient before, and they were headache specialist neurologists. And I think this comes up quite often, and something Clusterbusters is working on is our preferred physicians, and we're asking our community to share with us, have you seen a great headache specialist neurologist? Was your diagnosis simple? And it really should be simple, as you've explained, you know, with a tick list, that we have very distinctive symptoms which separate us from the migraine community or other headache disorders. So thank you so much for answering those, and I'm sure we'll have more questions in a few minutes if you'd like to carry on.
Well, and let me just respond a little further to one of those questions from NDL. So those are really important points about how do how do we get this data to neurologists and other doctors? It's every way that you can think of, unfortunately. You know, maybe that's good, maybe it's not. We do our best to get more and more presentations at national meetings and to publish papers about this, and little by little, as more information gets out in different venues, in different types of journals, in different types of meetings, the word will get out. It's always true that stories matter. And I can tell you from having had Brian and Bob, you know, come to the Headache Consortium of New England a few years ago and have patients talk to those headache specialists who were all knowledgeable, experienced people. It changed people's thinking right then and there. Any examples of that sort of thing, having people tell their own stories, stories matter, stories stick with people. So whether that's in a journal article, a news report, a newspaper article, you name it, but take every opportunity or make every opportunity you can think of to get your stories out there, because those are the things that will change people's minds over time. And it just takes, like anything else, repetition and persistence.
Indeed. I have one more question, if you wouldn't mind, Chris. It's from Steve. So his neurologist told him that the reason he had clusters is that his migraines prior to the introduction of Imitrex were untreated, and this led to him developing clusters. Does this have any credibility?
Not to my knowledge. And I think, you know, I would simply view that story from the perspective of some of that data from the cluster headache questionnaire we looked at earlier, which is in that group, kids were more likely to report symptoms that sounded like migraine. And so this neurologist said, well, the way you describe your headaches earlier sounds more like migraine, now it sounds more like cluster. So decided that the way to interpret that was, you used to have migraine, now you have cluster. I don't think I certainly don't see it that way, and I don't think that's what we understand about the biology of migraine and cluster, but it's understandable that somebody might have had that.
Great. Thank you so much.
All right, so moving on a little further, in the one of the questionnaires that was used in this Korean study was the cluster headache severity score. So I just want to say a little bit about that and the report about that one. So this is a Swedish cohort, 500 patients who were asked a lot of questions about cluster, including an effort to develop this scale, which basically was trying to get at a simple numeric answer to how bad is your cluster problem. And in that group of people, the average age was 50, the average reported age of onset was about 31, 2/3 were men, about 11% reported a family history, which goes back to what somebody else asked. About 17% reported having also had migraine or migraine symptoms at some point. The vast majority of these people, once again, had episodic cluster, and about 2/3 reported some predictable timing pattern day to day. Looking more specifically at the group who said they had some history of migraine, not surprisingly, a higher percentage of women than men reported that. These are roughly equivalent to the average percentages of migraine in women and men in Sweden. But it's interesting to note that the percentage of migraine history was lower in the episodic than the chronic cohort. I think that says some interesting things about how having migraine and cluster symptoms might affect the likelihood of developing chronic cluster, although we don't know that yet. So here is this cluster headache severity score itself. I just want to make the point that I don't happen to love this particular scale, and I don't think it's necessarily helpful to try to boil somebody's problem down into a single number, which is the goal of this. But notice, for example, that in scoring this, patients who had attacks lasting more than 3 hours were given a higher score than the others. So again, if you had what is considered to be outside of the range of what we expect from cluster headache, and if nothing else, if you have a relatively rare feature of cluster, very, very long attacks, you were considered more severe than others. I think that's an example of why a problem like this or a scale like this is difficult. And I would like to now ask another poll, which is, would each of you rate the typical duration of your attacks? So Andrew, if you can pop that in, I would be grateful. Thanks.
Go ahead and give it another 30 seconds for everyone else to get their responses in.
Great.
All right, and we're going to go ahead and wrap this up.
Super. Okay, so again, this is in keeping with my own experience. I think the experience of many headache specialists, that the most common response is 30 to 60 minutes. A significant percentage, a fifth to a quarter, say less than 30 minutes or 1 to 2 hours. But something like 18% of you today say that your attacks typically last 2 to 3 hours or more. So again, not what is expected from the diagnostic criteria or by most neurologists, and just another important point to make about the range. Using this severity score, this is just a breakdown of what the scores were and then what the percentages were. Not surprising to any of you, I'm sure, a higher percentage of patients with the higher severity scores were in the chronic group. Then looking a little bit further at that, saying that people who had a maximal score of 11 to 12, which is a small percentage of their group, that those patients tended to be older, tended to be less likely to be male than female, which I think is a really important point. And not surprisingly, were more often using oxygen as part of their regimen, although not even 50% of those patients, in Sweden at least. So what that says about access to oxygen or prescriptions for oxygen by their treating physicians, I'm not sure. But it's another important point about the differences between episodic and episodic and chronic patients in these surveys. Again, here we have just a breakdown of typical treatments used. Not surprising, both episodic and chronic patients reported using typically either injectable sumatriptan, nasal zolmitriptan, or oxygen. And also not surprising to any of the people at this meeting that a higher percentage of folks in the chronic group reported using other treatments, which I can imagine includes things like psychedelics or other drugs that are considered to be in the non-medical category. Similarly, in terms of preventive therapies, the vast majority in Sweden, at least, were using verapamil, and a higher percentage of those in the chronic group, not surprisingly, were using some other treatment because these didn't work. I think it's interesting to note that in Europe, there is still a drug called pezodifan, which is available, and which has very interesting pharmacologic characteristics, namely an agonist at the serotonin 2A receptor, which is, as you probably know, one of the characteristics of psilocybin, and also some antihistamine effects. So understanding that this drug is still used in Sweden or is not surprising. And perhaps, you know, somewhere in there is the thought that some comparison of people who respond to this to psilocybin or related drugs would be worthwhile. I don't want to leak into Larry Shore's time too much more, so I'll just very quickly summarize this, I think, very important study that was just published in a major journal, JAMA Neurology, from Dr. Burish's group, which was a systematic review of studies of family history, which is one of the questions that was asked earlier. So looking at studies that have been published over the last 30 years, 1985 to 2016, I'm actually impressed to see that there were this many studies that looked at the question of family history and cluster. Only one of those studies was a twin study, which is generally in medicine considered to be the most important type of family history study, at least when it comes to genetics. In those studies, looking at groups and a twin study and then case series, the range of reported family history was from 0 to 22%, on average about 8. Of the 5 largest studies, the range was again between 2% and 18. In the single twin study, looking at 37 pairs of twins, 2 of these pairs had cluster headache, giving a concordance rate of 5%, which clearly is evidence for a genetic cause or a genetic component to at least this type of familial cluster. Interestingly, looking at the pedigree, so family trees that were reported in some of these studies, they concluded that about 70% showed, or it was a 70% of them showed evidence for an autosomal dominant, meaning a single gene, which if you have it, makes it very likely that you will have cluster headache, as opposed to about 30% saying it was more likely autosomal recessive, meaning you would need to have 2 of these abnormal genes, or both of them be abnormal, in order to present with cluster. And a very interesting observation in this study was that the sex ratio was much lower in reports that talked about a family history. So if there was a family history of cluster, there was only 1.4 to 1 men to women. So a higher percentage of family clusters of cluster headache, in a sense, were in patients who presented as women than men. The last part is something we can talk about some other time. It's the study that looks at the ability of CGRP to trigger a cluster attack, basically saying that if you infuse CGRP during a cluster period, you can cause a cluster attack, but not outside of a cluster period. Very important piece of information about the biology there. And I will leave it at that. It looks like there's been a couple of other questions since the last group. I'm happy to see if there's anything there.
Okay, let me just have a look.
So can I just interrupt? Dr. Gottschalk, are you available to join us this evening for the Q&A?
Sure. What time is that?
It would be good for me to have that information.
Well, I'll look at the schedule, but yes,
Yeah,
I
and
think
I'll send you a panelist invite so that we have some other questions, but since we're running a little bit late, we want to jump into the next presentation, if that's okay.
Sure.
All right, and then we will get to, if you asked a question and you didn't get an answer, we'll either get it to you later or you can ask again this evening, but we will make sure that all questions are answered.
Great.
That's great, Chris. Thank you so much. What an excellent presentation. Fabulous information. We appreciate it very much. Thank you so much.
My pleasure.
Hi. So our next presentation is from Dr. Larry Shore. Now, Dr. Shore himself, a cluster headache patient, is a professor of psychology at the University of West Georgia and a licensed psychotherapist. His research, teaching and practice focus on the psychological effects and treatment of trauma. Dr. Shore, Dr. Mark Burrish and Mr. Stuart Pearson recently published an article on oxygen and presented the CHQ data nationally and internationally. So today he's going to discuss the psychological impact associated with cluster headache. Thank you, Larry. And may I just ask, are you happy to take questions whilst you're presenting, or would you rather wait until later?
I'm happy to take questions. Can you see the screen?
Yes, I can see your screen and the mouse, no problem.
Okay, good.
That's great. It's over to you, Larry. Thank you very much.
Thanks to you and everybody else. So let's see. I'm Larry Shore. One thing for you to know that I'm as my grandmother would say, I'm not a real doctor. So I'm not a physician. I am a cluster headache patient since 1983. I've been a therapist for a little over 30 years and a researcher for fewer than 10. So being a researcher in this is a little bit new to me. So I wanted to say a little bit about our research, which really just started for me with the question for all this anecdotal worst pain humans experience and suicide headache. I thought, well, surely someone has addressed this and been able to determine how painful this is, and it seemed like that was all anecdotal. So that's how our cluster headache questionnaire got started. So I'm going to run through it pretty quickly because I want to make people just aware of it who aren't sure what people are talking about when they mention it, and then move into the psychological aspects of it. So the title of our study was Cluster Headache, Investigating Severity of Pain, Suicidality, Personal Burden, Access to Effective Treatment, Demographics among a large international survey. Fortunately, I have been able to work with Mark Burrish. I just can't say enough good things about Mark Burrish and Stuart Pearson, who have both been instrumental. This simply wouldn't have happened without the two of them. Real quickly, the purpose and the rationale. There are a few large studies in the historic literature. The largest that I was aware of was Todd Rosen in 2011, a little over 1,000 people. There are certainly many credible accounts of people describing the severity of pain, but all are anecdotal. The nickname suicide headache, we haven't really been able to, beyond some very specific cases where we know that someone killed themselves because of cluster headache. Sometimes it's hard to know. And personal burden and disability factors are often not addressed. So our questionnaire, and I didn't realize how hard real science was until I started doing some real science. So if you ask 10 questions, SurveyMonkey kind of thing, it's easy to get everybody to participate. But we have the problem of, on the one hand, how much depth at the risk of losing participants, versus while we got them, let's find out as much as we can. So we wound up with 152 questions that were both quantitative and qualitative. I suspect some of you out there have taken the cluster headache questionnaire. And if, for instance, you've taken 7 different medications, you were then asked about the effectiveness, ease of access, and complications. There was plenty of room for descriptive or qualitative data. So we would ask people to describe various things. And we finally said, is there anything else you'd like for us to know? And we got, gosh, about 100 pages of people typing out what they wanted us to know. We had the support of the International Headache Society. Cluster Busters was phenomenally helpful. Social media, our data were gathered between March 27th, 2016 and April 20th, 2018. It was IRB approved and using Qualtrics software. It's hard to know how accurately this represents the entirety of cluster headache population. Sense is that people who somehow managed to get successful treatment, like myself, wouldn't be poking around the internet, may not have found it, whereas those who aren't getting the help they need are probably more likely to do so. There were also some problems with our inclusion and exclusion criteria. So part of our inclusion criteria was that you had to be diagnosed as cluster headache patient by a medical professional. So for instance, a woman I knew who was clearly a cluster headache patient said, I've been to 3 neurologists who all said women don't get these. So we had those kinds of errors. We wanted to try to quantify severity of pain, which is a difficult thing to do because pain is inherently subjective. There have been some studies where they stick your arm in ice water or things like that. We could hit someone with a hammer on the exact same part of the hand, but we've all seen the visual analog scale of how bad on a 0 to 10 scale, and different people will report the same thing differently. So what we're really hoping to do was to try and identify the differences. If we had a large enough sample, which we did, we were able to, within the same person, if you're a cluster headache patient and have also had some other painful, something like pancreatitis or something like that, then we could use within the same person. Wanted to understand the effectiveness of treatments, familial component, history of head injury, and also, rather than just call them suicide attempts, are there risk factors and protective factors? Are there psychiatric comorbidities, those sorts of things? So we also didn't want to require someone be diagnosed by having a headache specialist simply because there are people all over the world who just wouldn't have access to a headache specialist. We also, for the purposes of what we're going to see now, what I'm going to show you, I haven't limited those to 90% completion of the questionnaire. So this is going to be a larger number of people, respondents, than you will see in some of the other presentations of our same study. And the reason for that is, of course, for some people, this took 3, 4, 5 hours to continue. We used some validated measures like the Beck Depression Inventory, which was very time consuming. And we also had some areas where we didn't want to trigger people for suicidality, and you could skip those questions. Our respondents were aged 18 to 99. The 99-year-old actually was my uncle, but through marriage, not biologically. He was my great uncle married to my grandmother's sister. We had approximately between 10 and 20% of pediatric onset. And as Chris pointed out and others have pointed out, this doesn't bunch around. These were people who were 17 and a half and just barely missed the threshold. So clearly that's not the case. This is the posting we sent out. So a lot of you got it through Cluster Busters, also International Headache Society, and some social media. Here's how the survey looked. So if you said, for instance, in addition to being a cluster headache patient, I've given birth, past kidney stones and been shot, this is kind of how that would work. And you could do this on a phone, a tablet, or a computer. Some of what we didn't get into, again, the gunshot wound is an interesting question, but to really get at that data, we would have to have had a crime scene photo of where you were shot, what caliber, more details, and we, even without that, wound up with some pretty big data. So when you think about all these other features, so droopy eyelid, tearing, stuffy nose, none of that really matters. The defining characteristic of this, as all of us know, is the just extraordinarily excruciating pain. And this is one of those in the literature. There's severe and very severe. And I don't know what descriptors we can use that go beyond things that are defined as very severe. So extraordinarily, excruciatingly severe maybe gets closer. These three images, so all of us are familiar with the one in the center, which my guess is if you found a cluster headache patient on some remote island who'd never had any human interaction and showed them this, they would say, nod their head and point to their head or their eye or something. The image on the left is a heat map that was generated by you folks. So you can adjust the thresholds, and if you notice, you'll see a little bit of this blue in the back. So if we open the threshold too much, it kind of lights up anywhere anyone had clicked. But you had the participants had 10 clicks. And so this isn't something done by a medical illustrator. This is actually tens of thousands of patient data points from all over the world. So you can see that that's primarily where the pain occurs. How painful is this? Patient admitted for #psychiatric disorder, which my guess is was in the ER and wouldn't sit still or lay still and rolling around on the floor banging their head, seen by a neurologist, and wound up self-enucleating. And as the medical professions will say, expired, which is a pretty soft word for died. The eye was found in the bedding, and this isn't the first or the second or the 10th time we've heard this. And my sense is migraineurs, they don't carve their eyes out. This next shot, a 56-year-old male with a history of chronic cluster headache. Over a period of 2 weeks, he became extremely depressed, sleep deprived. During an acute nocturnal episode, aimed a shotgun at his symptomatic eye and fired. So those little dots are shotgun pellets. So please don't try this at home. I've been trying to hunt down John Rothrock. If any of you know, at the end it says the patient survived and at discharge exhibited no significant neurological deficit, which seems pretty extraordinary to me. So without filtering down to the level we needed for CMS and to really fight these battles, we had approximately 3,000 respondents from 73 countries. Our sex ratio was about 2 to 1 male to female, which it seems like that's kind of where we're heading these days. I think the 6 to 1 was the days of woman plus headache equals migraine, that sort of thing. Are you still able to hear? I just got a warning,
Yes.
my internet is unstable. Okay.
We can hear you
24,
well.
okay. 24% reported previous head trauma, which is really significant. On the other hand, that means the other 76% didn't. 14% reported a suicide attempt. Nearly half reported the financial burden as very severely or completely unmanageable. 73% reported moderate or severe impact on mental health and emotional well-being, and this has been essentially ignored, this particular aspect, and that must stop. And I suppose primarily that's because people are so desperate for a physiological treatment that all of what comes along with being a cluster headache patient or a supporter gets kind of tossed to the side. This is just a map of the countries we had participants from. So we did have people from virtually across the globe. Oops, I need to go back to the last slide. So this is really kind of the money shot. So for cluster headache. So keep in mind, of all of the people who had experienced cluster headache, this is 2,795 who also reported one of the following. So the 602 who reported childbirth as well, 7.2, migraineurs 5.6 compared to almost 9.6. And this isn't a linear scale. This is probably more like a Richter scale where it's more than just a 10 is twice as bad as a 5. Shingles, arthritis. As you can see, pancreatitis, which my understanding is pancreatitis, you're in the hospital with an IV drip of morphine. Chris, could you just nod your head or shake it? Is that the case typically? Yep. Yep. And when I worked at the hospital, at the ER, when somebody said they thought they were passing kidney stones, we would tell them on the phone, how bad is it on a scale of 1 to 10? And if they didn't say a 9 or a 10, we said, go home and call your doctor Monday morning. You're not passing a kidney stone. And I've shared that before and had several cluster headache patients say, I did exactly that. And they told me to go home, and I pulled over to the side of the road and passed a kidney stone. So this is quantitative data rather than qualitative data. So just to kind of clarify, this was cluster headache patients who have also had these other conditions. And so pancreatitis, we had 53, kidney stones 421, and you'll also see the standard deviation and variance are quite small for cluster headache compared to, and this shouldn't be real surprising, things like arthritis that have quite a bit of variability. Let's see, next slide. Uh-oh, my mouse doesn't seem to want to work.
Larry, would you answer a question for us?
I sure would, yes.
Thank you. We've had a question asking from Mark, was your uncle that you spoke about, and I've heard you speak about your uncle before when you presented for us in the past, was he still having cluster headache attacks at 99 years of age?
No, great news. He reported that they'd gone away when he was in his 70s. So that's some very good news. Also wanted to mention that my own kind of bias, it's both helpful and maybe not in some ways to be a cluster headache patient and a researcher. So my age of onset was 21. I'm a male. Some of even the stuff from the 40s and 50s, hazel eyes, bingo. Brian McGeeney's favorite diagnostic tool, the leonine features, and that isn't meant in a complimentary way. That's kind of a ruddy face. I've been told by my wife I have those, and abrasive personality, certainly. And of course, what we've found out about abrasive personality is that these are patients who get no help from their doctors, so they go back pissed off and complain, and the doctors blame that on the patients. So, cluster headache. Does a cluster headache ache? And I think the answer is no. Nobody really describes this as ache. When I've broken my ankles both times, and yes, that aches. A hornet stings, a burn burns, but a cluster headache, it just doesn't capture it. It doesn't really ache. Most of us would say no. If the diagnostic criteria required the description of the pain as an ache, my guess is that very few of us would meet that criteria. So I wanted to talk some about this notion of PTSD. So there will be a DSM-6 as surely as there will be an iPhone 14. I was involved in as a collaborating investigator for the DSM-5, and I say that I'm confessing, not bragging. The area I worked on was non-suicidal self-injury. So some interesting things about that. One, the DSM committee decided to kick that can down the road and classify that as something worthy of further investigation in the future. And also, many cluster headache patients engage in self-injurious behavior during an attack, and that that doesn't mean that they would meet the other diagnostic criteria. So the verdict is in all ways that matter, most of us and vicariously our loved ones suffer tremendously. And are similarly are traumatized by this condition. So for some people, and most of us have had the experience of being pretty reluctant to tell people we have this disorder, because when we say, and I don't have the tool for a quick poll, but my guess is that if we said, how many of you have said to someone you suffer with cluster headache, and they've said, I get those too, and what they described as seasonal migraine or allergy headaches or something like that, so we learn not to ask. Curiously, if you say to someone, I have a neurological condition called trigeminal autonomic cephalalgia, they have no idea what that means, but are more likely to respond with, oh my God, you poor bastard, or something like that, or can I have your watch if you die, or something like that. So I just really wanted to emphasize that, yes, there's something PTSD-like to this. So part of what we were able to determine is, in terms of suicidality, we asked people both when they were in cycle, during an attack, or out of cycle. So 30% of our respondents reported suicidal ideation when out of a cycle, or for people who are chronic, during some period of remission, or when they were not having an attack. So certainly elevated, but what really is striking is that 71% of our respondents reported suicidal ideation during an attack. So what that says to me, and is consistent with my own experience, is that while some of this can be attributed to what this takes from my life in an overall, whether it's losing one's job, a loved one, a relationship, that during an attack is, I would kill myself to stop this agony. Or for those of us who have the experience of the external beast or demon or something like that, I know for me it's been, I would kill it and I would just be collateral damage. So it doesn't really feel like suicide as much as a desperation to make the pain stop. 13.7% of our respondents reported suicide attempts. So the prevalence using the National Survey on Drug Use and Health is that would be 4% of suicidal ideation, and we're at 13 or 14%. So there's just absolutely no question. When patients are out of cycle, they're 3 times more likely, and during an attack, somewhere between 10 and 20 times more likely. Psychedelic treatments. So I was rather surprised by this. We obviously have people who have taken psychedelics for other reasons, and some people who are very much averse. We've had people at Cluster Busters who have said, I'm a cop, I can't take an illegal drug, that sort of thing. And also some concern about what happens to people who don't want this experience. Should they microdose? Should they be with somebody? And very surprised that we asked not only about physical complications, but psychological complications. And if you look at some complications or severe complications, they were very low with psilocybin and with LSD. So I would, I think what we need to do is develop some guidelines that if you're going to do this and haven't tried these substances before, start with a lower dose, give that a try, and some guidance on set and setting, and have someone with you you trust, that sort of thing. So in summary, this is possibly, and I think that our desperation or hearing whether it's the most painful or the second most painful, is really a search for someone to validate that this is just fucking horrible, and this isn't like a migraine, this isn't like some of these other conditions. And I don't want us to ever get in a war with, is there anything that could possibly hurt worse than this? I imagine there is, but it's probably the most painful recurring medical condition. So in other words, if they say this is about the same as having a finger chopped off without anesthesia, well, that can only happen 10 times. Some of the folks who suffer the chronic form, Bob Wald and many of you perhaps, there are people who have had thousands of cluster headache attacks. No one's given birth 1,000 times. No one's been shot 1,000 times. No one has had pancreatitis 100 times. Nobody's been shot and has to look forward to, you'll be shot again tomorrow 3 or 4 times, and then probably the next day and the next day and the next day. Poorly understood, although pediatric onset is not extraordinarily, it's not extraordinarily common. It's not recognized in training or in treatment, as Chris said. And so for most people, it's not pediatric, but for a surprising and alarming number, it is. So these are kids who aren't getting treatment. They're being misdiagnosed. And there are safe and effective treatments, but many people have difficulty getting an accurate diagnosis and then getting accurate treatment. So this is why the fight for oxygen is so important. As I said, the elevated suicide rates seem to be a response to the intensity of pain. So people should be monitored, and loved ones and supporters get the firearms out of the house. The likelihood of stopping a burglar from stealing your stuff is much lower than your loved one taking their own life during an attack. In terms of the psychological aspects, and this is really the most important part, this takes an enormous psychological toll, both on sufferers and on loved ones' supporters. In recent years, I've had the separate closed groups for supporters and closed groups for the for cluster sufferers themselves. And so for the sufferers only groups, there are things that we talk about in that room that you simply can't understand unless you've been through. And also for the supporters, and it's been contentious at times to have supporter groups and have someone say, I'm a patient, can I come with my partner, and be told no. That's been a special place for people to be able to say things like, this feels like the third party in our relationship. And when we got together, I knew this person suffered with headaches, but I didn't know that this was going to control our lives. So there is support out there. What I'm going to recommend you do, and hopefully we'll eventually develop a good therapist or recommended therapist list now with telecounseling that may be more possible. Like you would do with a physician, don't take 50 pages, but take 8 or 10 pages or 3 pages that describe what this is. And if people aren't going to read it, then that's the wrong doctor for you. That's the wrong therapist for you. So I'm sorry, I can't see the questions, I don't think. So I'd be happy to take them.
Yeah, I have a few questions and
Sure.
and a few comments. So everybody thinks you're amazing, and we agree with that. Larry has been a marvelous supporter of Clusterbusters and a great friend to all of us at Clusterbusters. His presentations was there, and his closed groups are invaluable to so many people. So I would just like to thank you on behalf of Clusterbusters for that. So our comments here, we have someone who's asked, will you, I don't think you are scheduled to do a closed group session this time. I know you normally do it at our inpatient conferences.
Yeah, I'm not a fan of Zoom therapy
Right.
and teleconferencing, and you folks have each other to support. And mostly what I've done, it's not like I apply any treatment. I mostly do what you folks do, which is make a safe space for people to express themselves to one another. So you folks have pretty good manners and are pretty kind and accepting of one another. So please do some of this on your own. Next time in person, I'm certainly happy to do that.
That's
but
wonderful.
no, I'm not going to have a Zoom.
No,
a Zoom.
and I understand that. I think I totally agree with you for things like that. We have our open social space where people can go and chat amongst each other. But for the wonderful sessions that you do for us in person, I agree, in person is better and nicer. Lots of compliments, and I know you don't take compliments very easily, but
No, I've got that abrasive personality that we cluster headache patients have. Yeah.
Well, you know what? I've known you for a number of years now, and I've never seen that. Never. But yeah, you're very well respected within our community, within our family, and we are so appreciative of you taking time out to be here with us today. And if anyone has any questions afterwards, we'll do our very best to get those to Larry and get an answer back to you. And in the meantime,
I'd be
thank you
happy
so
to. I'll be around, so if you want to email me questions, feel free to do that, and I'd be happy to get back. Thanks to
Great.
all of you. Please take care of yourselves and each other. Thank you.